hey, if you're mouth breathing, it can cause more decay. I mean, I don't know if most people know that. When people are like, if you mouth breathe, your mouth's dry. If your mouth's dry, you have no saliva. You have no saliva. You have no antibodies. You have no antibodies. You have nothing to protect your teeth. You're going to get more decay. You can brush your teeth all day long.
Hello. That's how it's done. Give it. Hello, everybody. Zach Couples here. And folks, if you are someone who mouth breathes, snores, has sleep issues, maybe you got sleep apnea, if you or your kiddos have had a history of eustachian tube dysfunction, or you're someone who's had enlarged tonsils and adenoids, you had them taken out and you're wondering why, or maybe you're just curious why Steph Curry chews on his mouthguard the way he does. If that sounds like you, then you definitely have to listen to this episode of the Zach Couple Show with my girl, Melissa Mugno. If you don't know who she is, by golly bows you should. She is one of the best myofunctional therapists in the game. If you're wondering what myofunctional therapy is, it's kind of like physical therapy for the mouth, incredibly important with dentistry, among other things. And she is one of the best in the biz. In fact, she is the myofunctional therapist that your boy Big Z approves of because she works with me and has done an incredible job. We talk about all of the things that I mentioned and more. We also go into what exactly myofunctional therapy is, where it fits into the healthcare system, why belly breathing is totes my goats overrated, why do we clench, why do we grind, and why, folks, behavior change is the hashtag major key when it comes to getting people better at these types of habits, especially anything that is related to mouth breathing. If you want to learn more about Melissa, you can find her at melissamugno.com. But for this particular podcast, show notes, the podcast, the YouTube video, everything, modified transcripts. If you want it, you go to zachcouples.com/Melissa, and you'll get everything you need there. Without further ado, let's give it a shot. So Steph Curry walks into your office, and he asks you, hey, Melissa, why is it that I like to chew on my mouthguard so much?
So the chewing is because of his airway.
Do tell. Tell me more.
Okay. So in sleep dentistry or airway thing, we've really come full circle to understand that like chewing and clenching has a lot more to do with like a deficiency in the airway than it does anything else. So there's habits that are created that actually kind of stimulate the jaw to come forward, and there's a feeling that feels good. It gives us more air, a little more serotonin overall, and it actually will give you a lot more clarity, right? Get some good oxygen, you feel better. So that's actually what's happening. So the chewing, a couple times you do it, you're like, oh, that feels good, right? Most humans continue to do things that feel good, stop doing things that feel bad. So they start doing that. But the thing with Steph Curry that's quite interesting is he doesn't just chew on it. He does something even more interesting. He flips it out of his mouth and hold it. And what I was saying to you before was, again, I have not worked on Steph Curry, so I do not know. This is just me looking at it. I was intrigued by it. My husband brought it up and said, hey, this guy's like really known for doing this. And I was like, interested. And I've always thought there was a big sport connection. I started kind of like looking at how thick his mouth guard was. And I'm like, oh, it's at least 2 millimeters, 2.5. And one of the things we do that dentists will do or to help patients that have sleep issues is they'll actually open up their bite, open up the jaw, I guess, so they can't close all the way, which naturally will allow their jaw to come forward. And that does is it opens up the airway and allows for the air to flow easier. So he's holding it and he's protruding his own bite. And you can see it's literally bringing his jaw forward. So then I started doing research, and I used to make a joke about basketball, right? So my husband loves sports, and I used to not let him watch it while I was home because I used to call it squeaky sneakers. Because all I would hear was the sneakers. Yes. So I wasn't like always like a really big fan, but you know, if it serves me, I'll do it. So I started looking, and then I watched some YouTube video, and I saw that Forbes, I think it was, I might be off, one of the bigger publications did an actual like survey or did some type of research of how many free shots that he made when the mouth guard was out versus when it wasn't. And it was like extremely, by far, he was spot on. Like I think it was something out of like, I don't know, 90% or something really, if not even more. Don't quote me on the numbers, but And I was like, oh, of course. Like, it was a no-brainer to me. I'm like, because he's breathing better. Oxygen will absolutely get you focused. And therefore, it's more comfortable. So why wouldn't you keep doing it?
Yeah.
So now it's become this whole thing. I guess like tons of athletes do it. And I was like, yeah, of course. Like, yes, it protects your teeth, but there's a lot more to it.
But when you're clenching as well, how does that open up the airway then? Because I would think.
So you are correct. The clenching doesn't. So I'm sorry. The clenching and the grinding is not opening up the airway. It's a side effect of having a reduced airway. It means that the body, so the vagus nerve, and I like to keep things very, you know how I love my analogies.
The fam is they're next level, so they know Vegas.
Okay, so but my crew and my people I'm talking to, not my dental people, but my patients, do not know Vegas, right? So I use very simple, I love my analogies. Yes. So I call it like the body's fire alarm, right? And so it triggers something. And so what's happening is the body knows it's getting reduced amount of airway, of oxygen. So it's doing something to make sure, hey, are we good? Are we open? I use that as an example. So it's going to create some type of function, some type of habit to make sure everything's good down there. So the grinding. And I have this little theory that we grind when we're kids because we're carefree. Yeah. And we clench when we get older because we're trying to control it.
Gotcha.
Because you don't notice way more adults clench than kids. And I realized some of it's not absolutely proven, but my adults that grind are usually my cool cats because they're chill. They just grind it out. They, let that jaw flow. The adults that are like, they're trying to control. They don't want that feeling. They're trying to control that bite. They don't know why their jaw wants to move. So I believe the clenching has a lot to do with trying to
prevent
control.
It almost.
Yeah, exactly. Because their natural feeling of like, I don't want that. They want to feel like they can do this. Also, I think it's I like to kind of go into all this is so much more connected to the mind and, anxiety and all, like so much more mental health and stuff like that. I think it's a natural thing that happens as we become adults that we just want to control. We just and where do we wear it? If I'm feeling as I'm saying, I'm having feelings, tons of feelings, and all those feelings, and maybe I don't feel like I have a place I can put them out, or I don't even know why I'm doing it. I build some type of subconscious behavior to take it out on, in a sense, and then we activate the buccinators, and then we're straightening out all in here, and then we're doing all this kind of stuff. And usually this comes into people that can breathe through their nose. I don't know about your fam and your peep out there, like, how we kind of connect, nasal breathing. So kind of like to go real quick and bring it full circle. So the concept of breastfeeding is really, yes, you get a lot of cool nutrition value of it. But one of the coolest things that happens is it actually teaches you how to breathe and eat at the same time, right? So get that tongue up. If that tongue's strong, it's gonna push the nipple up and then be able to help extract the milk. And then the baby's actually letting the mom's body know, hey, you got to keep producing. So, that's a whole other, that's not my specialty, but I have to know enough about it. And so like when moms don't produce milk and don't have all those things, they automatically assume it's their fault because they have mom guilt. So then it's like, I just got to make my baby breathe, be able to eat and stuff. And they think that, the formula is doing the trick, but what's not happening is that then the bottle goes in and now the tongue goes down. And so I have this concept like, have any of you been like, God, I just want to get a bowl, I just want to get something to eat and I just want to lay flat on my back and just, nobody does that. It's the most ridiculous position. And you might, hold baby like this, like, but I just always think like as an adult, would you like want someone to feed you? Like, how do you swallow like that?
And then you can't control the rate at which the liquid's coming in when it's a bottle versus when you're breastfeeding.
Well, and then you have to love the nipple companies. They actually like say, oh, add more, make it go quicker the older you get. Like, make it easier. Like, just flow it in there. Like, no work needed. So, and I'm simplifying it and making it silly, but I think it's important sometimes just to keep it simply stupid and just be kind of make it a little bit more accessible. So when those things don't happen and you don't build this awareness, like build this ability to nasal breathe, or if you don't have a grandma that used to say sit up straight and chew with your lips closed and breathe through your nose, and unfortunately we live in a world now manners kind of out the window. Kids are and looking at the phone exactly, so that's not being built up. So some adults, you'll see that they absolutely could still have an airway issue, but they like figure out how to do this. They're breathing through their nose because they had to learn, they had to compensate how to figure out how to do that. But it all kind of ties in to the whole thing.
From my standpoint, when we see someone clenching or grinding on the PT side of things, usually that's done to restrict available movement. So you almost make the system more rigid. And to your point, when you're talking about who is this, it's those type A people. And a lot of times, I forget what book it was, where they talked about the chairs in the waiting room of a cardiologist, and they had way more. Oh, marks
into. Oh yeah, yes, in the in the armrests.
Yeah,
because like they're clawing at it, they're trying to grip. They have a lot of like built up energy, anxious, fight or flight, right?
Yeah, and maybe it's just to change the pressurization that's going on in the airway, and that's what it.
I laugh a little bit, when people be like, airway, dentistry, PT, speech. What does that have to do with it? I'm like, I'm not gonna lie. I've gotten to a point. I'm like, just want to roll my eyes a little bit. I'm gonna be like, oh yeah, air. Who needs air?
Yeah,
Like I'm like, oh no, like, or I was telling you earlier, like somebody was like, oh, we don't have enough research, and I just want to be silly and be like, so we don't have enough research on how important oxygen is. Like I'm sorry, like I was like, we don't.
Yeah.
Oh, but not enough on this. We don't know how oxygen affects this particular specialty of a specialty, right?
Yeah.
And I think that's medicine that we've, unfortunately, it's like it's a double-edged sword, right? We're the most specialty people. We're like, you have a doctor, what's your general doctor do? I might feel bad. I mean, because then you have to go to this guy and then this guy, and then you talk to that specialist, and he's like, oh, I don't do that. You don't do anything else but the finger, like it's just. But so it's very, we're this. So when and I'm not joking, there's professionals out there, and they'll be like, well, there's no research, there's no exact paper saying how important air is to affect how your fingers and to me, it's like, really, you've gotten that narrow-minded? Like it's if you haven't seen something that directly said, hey Zach, this affects your job, like you don't believe it. It's hard for me to get there. I say to everybody, I was like, so we all took anatomy, right? Or did everyone get that little song, the elbows connected to the, right? Everything's connected. So no? Okay, cool. Like we'll just move on.
Because we are so advanced in many ways, medicine-wise. I mean, you look at...
Keeping it simple is very hard.
Yeah, wait, you need me to breathe through my nose, and that's going to fix things.
I just paid you to tell me to breathe. I am breathing. I'm like, well, I mean, that's left to be decided. Yeah, right? I mean, and obviously, you guys are watching me. I'm like, I'm not just I'm not just the president, I'm also a member. Like, it's, I do it because I can't breathe that great either, I have a lot of... I have a lot of breathing disorders.
For sure. Well, and I think most people don't even know that your specialty exists. Myofunctional therapy. I mean, when we were talking off air, it's like, how did you get into this? It's like,
I don't even know.
Yeah.
And and it kind of almost, I'm almost gonna say something of it. Like, I want to give an homage. There's amazing myofunctional therapists, and there are people that have been doing myofunctional therapy forever, right? Like there's. I mean, we could go Joy Muller, like Sandra Colson. I mean, there's some really amazing. I mean, we wouldn't have it. We wouldn't have had the foundation we have without all the hard work that all those people have built into what it is today. And I'll be honest with you, I don't know if I'm the best representation of myofunctional therapists.
You're just my favorite.
Thank you. Because it's been more about connecting the dots for me. And I think myofunctional therapy happened to be a vehicle that I could drive that allowed me to go to all these places. And I don't think that would maybe be the same for most. I think most love the skill and the passion of myofunctional therapy and what it is day in and day out, and how to make the exercises better, and that one-on-one with the patient. I mean, I love my patients. Don't get me wrong, and but it's more of this bigger thing for me. Like, I look at it like I always was looking at the teeth. I was more interested about like, how is the tongue affecting the teeth? I loved like the side effect issue of stuff. And then once I got one, I was like, I needed to go like open the door for somewhere else. And probably my ADD and ADHD helps with that. Like, so that I just couldn't stop.
Yeah.
And so when you asked in the beginning, my journey, very untraditional. Like, it was, I have a background. I was an orthodontic assistant for a long time, hygiene, whatever. But I ended up not really even practicing my real calling was I was really lucky enough. I had a really amazing mentor, good friend of mine, orthodontist, and I don't know, I guess he saw something different in me and he realized I was much better at, running it and selling it and implementing it and making sure the patient and being that liaison to connect everything. But at the end of the day, what does that mean? It means making sure the numbers and the production and collection was good, and I was good at that. And we, one thing went to another. His father was a neonatologist, and he became very aware, him and his wife, very aware in doulas and breastfeeding, and then tongue tie release, like baby tongue tie releases kind of started that. And then we kind of started talking. I know your homies and people might not, I've been on Dental Town. I just said homies. Sorry. The guy on Dental Town always goes with my homies out there.
Yeah.
So,
we're the fam.
Oh, you're the fam. Sorry.
ZachCouples.com.
Okay.
And fam recognized fam.
So one of the things we were talking about was we had this really amazing pediatric dental program, group, and we had ortho. And, we were booming and patients were flowing and we had a great little model going, but there was this little hole, right? Because I would get all the pediatric dentists, they were always referring, but then I would get them to the ortho and they couldn't start because they didn't have their 6-year-old molars in yet. And then it was like, oh, well, okay, I did everything. How do I make that work? So long story short, I'm from New Jersey. We don't have a very long summer there. And the doctor comes in and he hands me this thing and he's like, we're going to go to this course. And I'm like, in August in New Jersey? No, thank you. But it ended up being a myobrace course, MRC. And this class 3 case came up and it was this moment of, I'll be honest with you, I don't know if it was 100% like, this is going to change the world, but we were starting to have patients ask for, why, I think I was telling you the class 3 bite.
Yeah, and so the class 3 is essentially an underjet where the...
Yeah, it's where the lower anteriors actually come out forward more than the maxilla, right?
Yep.
So
mandible more in front of the maxilla.
Yeah, so just your homies so underbite, lower right, edge to edge, technically class 1, right? So if your kids are growing this way, there's usually 2 aspects of it. One is that it's an actual genetic, right? There's an uncle, grandmother, you can find it in generation lines. Or one kid has it, which we now feel pretty confident is more about tongue force. The tongue is sitting low, so it pushes the jaw out down here instead of pushing the maxilla forward. So the long time, and for the most part, I'm not going to say that it's not still somewhat the standard, is the only real way to fix it is to do surgery.
Yeah, and a lot of times they'll break the jaw and pull it back as opposed to...
Yes, which that's a whole other political aisle.
I had a friend who did that.
Yeah.
And I told him, I didn't know him at the time, he was a coworker, and I told him ahead of time, my buddy was like, don't do this. If anything, you got to bring them both forward. But
And did you know that this was before you started doing it?
Yeah. Oh,
so you were already a little
I know like a little bit. I knew like a little bit of airway stuff,
Okay.
and like some of my earlier things, it was more about using splints to change.
Oh yeah, you
jaw
showed,
positioning.
Well, you
and stuff
showed
like
me that face profile you had.
Yeah, it looks bad. I know, man. Well, I never had a girlfriend back then.
You kind of need a little symmetry going.
Exactly.
Yeah.
But so we started with my first appliance that I ever had was a Gelb Splint.
Really?
Yeah, just something because I had my wisdom teeth were still in, and I had no intrusive movements in the jaw, and so we used the Gelb to try to get me a little bit extra just from a movement perspective. But then the fix was to get the wisdom teeth taken out. So then we went that route. I wasn't really having sleep issues then.
No, yeah.
But then as I got older, it was.
But you did do your sleep test, sleep apnea?
I got upper airway resistance syndrome.
Oh, you do? Okay. Which is funny because don't be funny. I wonder because of your athletic and all those things that, because elongation in the sense you did, it would look like you might be more of a sleep apnea patient. I mean, that's probably my kind of thing, but really UARS, upper, so you and I are the same.
Yeah.
Like the same club, huh?
I know, right?
But yeah, so that whole kind of, exactly, trying not to go forward. So, that bite profile of this, so we had a mom that had 3 boys and all 3 of them had that underbite. And here we were we all had fancy offices, beautiful offices and had come. And, the mom was just kind of really? There's nothing else? The 3rd boy, surgery's the only option? And it was true. I don't know, we didn't even have a creative option to give them. And So we, go to that course, and one thing led to another. We saw this could work, and was the concept like, let's give it a try and see where it goes. And I guess I'm fairly decent at selling stuff. Like, I want to say selling, guiding people into a way of helping them see why this could work for them. For sure. And I did really well at kind of implementing this possible functionality and using this myo brace system and in that office. And then, to be honest, we implemented it, and we really started to notice, okay, it's great, the theory's there, but the execution was rough. Like, what were we looking for? How did it fit into our model? Like, and, it kind of went from there. So the journey then, long story short, kind of went, and then I really started to crave the need of like, okay, who created these exercises? Where did they come from? And that actually kind of brought me full circle to Sandra Colson and realizing she was a huge part of working with them, and maybe, and I don't know all of the background of it, but I definitely wanted to keep them. And then finding out that her husband was an orthodontist and she was a speech therapist, and they'd been doing this stuff for years and getting amazing results. So there were so many great people doing things we just didn't know. And that kind of was like, okay, I was curious in that. I loved the connection of the dentistry, and it just resonated. It made sense, like why we had so much relapse, and we couldn't really explain it. And listen, I was really good at explaining why we had relapse. I used to say like there were tree roots, and they would go home, and like
yeah.
You know what I mean? I don't know, and I believed it, and I didn't want patients to think we didn't want the best. So then it just kind of opened up one thing. I also started to notice, just from in consults with different orthodontists, like how first beginning of my career, we definitely were, I didn't hear tonsils and adenoids so much. Like we weren't bringing, like so if an orthodontist is doing his, consult, he's usually rattling off stuff, the type of bite, class 1, class 2, upper, posterior, crossbite, whatever, convex, all the different profile stuff. And they might say, within normal limits, but I noticed the last, I want to say like 08, 09, definitely enlarged tonsils. Maybe we should send him to an ENT. And I kind of remember being like, why so much? And they're like, I don't know. They're just like in my face. Like, in a joke. He's like, I know why, but he's like, I'm definitely, they're big. They're just more big. So that's when I started hearing like this connection to all of it. Right. But the truth is, like, my real aha moment was, so I was an ortho assistant for an orthodontist that I will say was amazing as an orthodontist. Like, you could find his smile, like a smile he did you could pick a smile across the room. Like, you just knew it. I mean, it was big, it was broad, right? And that was my first ortho assisting job. And so appliances and what I learned, I didn't know any different. And so, not that your fam will totally understand this, but he only used removable appliances, nothing cemented.
Really?
And he would use, and we always were doing early expansion, twin blocks, Maras, CD sliders. We would use everything was removable, prop that bite up, pull it forward, and expand the heck out of it.
Wow.
Now, how do I say this in a nice way? He had I guess back then I probably would have called it an arrogance. He commanded the room, right? Like you didn't question him. He just carried himself in a way like I'd never seen anyone. A mother, he would look up over the glasses like there was no, sorry. Like, and it was because of that, there was no option. Like, if Bobby didn't wear it, like, that's your problem. Like,
yeah,
then you should make him wear it. Like, so that level of like expectation. So why that's important to understand, like, so I go through, and I remember one day we're in the office and I know nothing, right? Like, I'm just figuring out how to do this. He walks by, and the patients don't hear him, but we do. And he's like, God, somebody should cut that kid's tongue out of his mouth. It's messing up my teeth.
Whoa.
And I mean, like, it sounds dramatic, but it, like, in his, like, now, I totally understand, but I didn't. I was like, wow, what a jerk, right? Like, doesn't care. So, come all the way full circle. I'm now in that myo brace class, I'm doing it. And it was like this light went off. I was like, oh my gosh, this is what he was talking about. The kid was tongue thrusting. No matter what he did to that bite, he couldn't close it.
Because the tongue kept pushing the teeth.
Yes, that's what he meant. He's like,
wow.
God, that tongue is going to destroy everything. So he knew it. But the crazy thing is, if you go back into his story, he was originally an engineer. He was a mechanical engineer prior. Then, after getting married, had one profession, went back in dentistry and became an orthodontist. And because of so orthodontics is engineering, right?
Yeah.
It's all about force and movement. And I think that's what makes most orthodontists very specialized, is because they can see things in a different way. It's very different than than dental school.
For sure.
And I think even having that full having that full engineering career and then bringing that into ortho, he saw exactly what we were talking about. So we took it to that another level. And so this concept of kids not being able to wear removable appliances and get things done was not a reality to me, because I saw it was done all the time. So now I don't work for him. Years go by, I go back to school and all those things. And I noticed like almost every orthodontist just cements everything in. And I didn't even know you cemented it in. The first time I was like,
really?
Well, why wouldn't you just give them the colors and So I think these like really, my journey of like all these different things I did, and then I was able to have these moments of like, whoa. And I was in these different areas of dentistry, from understanding how the office runs to being the assistant to cleaning instruments to doing hygiene. Like it all took me, like I almost needed that whole journey to be able to see this. And that's it. That was the most powerful thing, was like, oh, that's why the teeth keep relapsing, because we didn't address the tongue thrust. Or like we didn't retrain the tongue. We would maybe tell the kid, hey, Bobby, try to put your tongue up. Or we'd put a habit in there or something. Well, anyone that's ever had a real habit, it's not always very easy to overcome it, right? Especially if you don't even know why you're doing it.
Yeah.
And mouth breathing and tongue posture, I mean, like if you're drinking all the time, you kind of know what you're doing is wrong, right?
Yeah.
Or you know what the culprit might be. Like maybe this is what's causing this.
Yeah.
But if you don't even know that it's wrong to mouth breathe or have a low tongue posture, now I tell you, oh, you have a breathing issue. It's because of your tongue. What? I don't need, like, how do you do that? How do you fix that?
Yeah, because it's not like especially when it's so common to see people mouth breathing or to see people not focus on tongue
look at how
positioning.
it's changed. So you look in Disney movies.
Mm-hmm.
So if you go back to like Snow White, or like the older ones, all of the characters are lips closed.
Really?
And now you go to Frozen, Elsa, not the movie Frozen. She, I think it's Elsa. No, Anna is sleeping. Mm-hmm. And she's drooling with her mouth open.
Wow.
So even
I never even noticed that, but this probably makes sense. Like Sleeping Beauty.
Really?
Sleeping Beauty wasn't snoring.
No.
No.
Lips closed, breathing through her nose. But poor Anna.
Wow.
Breathe. And then the funny part is, the other thing with the movie is there's a part where she's like singing and she's going, and I'm like, well, I guess someone told her she needs some myofunctional therapy. Like, that's all I kept thinking.
If Frozen 3 happens, you are going to get casted.
Yeah, what was it? Somebody actually said, I will give Dr. Tara this. She said, I can't even let my kids watch Disney movies anymore. I mean, all these poor habits are but because the society concept has changed, that's what's norm.
Yeah.
So they went along with what's normal.
Yeah.
Isn't that, I don't know. I find that stuff to be crazy.
When you have such can we say an epidemic of this? Because, I mean, it is. I guess.
I don't know. Are you allowed to use that word right now?
I think epidemic's okay.
Okay.
But
we'll stay away from everything
the P word
Okay.
can't be said. That could get demonetized. For
yes,
that,
okay.
But if you have this epidemic of mouth breathing, and maybe this is where you are realizing, I don't want to say the shortcomings of myofunctional, but the limitations. I have limitations as a PT.
Yeah,
that's why
we all have
that's why I
hurdles.
talk to you, and that's why I work with Dr. Hockle, and that's why I there's an optometrist in town that I have to work with sometimes. So where do you start? And I know you mentioned breastfeeding and things like that, but where do you start to tackle this?
I mean, ideally, in a perfect world, that's where it would happen, right? Like that every baby that's born, somebody with knowledge and a true understanding is there to address and make the decision of whether or not the baby has a tongue tie and has a tongue tie to the new protocols and standards, not what maybe somebody was taught 20, 30 years ago. Because I guess my favorite question was when people go, is this new? And I was like, well, why do you want it to be like, no, we've known, but is it finally that we're able to come together and figure out a way to fix it? Mm-hmm. Yes. And isn't medicine always supposed to be growing and evolving? Like, I don't know. I just always like, you're still watching a black and white TV. No, I mean, it keeps getting better and it grows. Sure. So I would hope that would probably be the ideal place. And so I think our lactation community is really picked up. I mean, they've just done amazing, and they're really trying to they have to almost assess.
Yeah.
But I think some of their limitations is once they assess it, where do they send it? Who does it? And then the question is if somebody isn't right then and there, can't just has hospital rights or whatever, can come right to the hospital, just do it real quick and get that breastfeeding on. Every time that, right, every hour and every day that goes by that the baby and the mom are struggling to connect or have that go on, isn't that going to be harder and harder to get to the person? So now we go out longer and longer, and now time starts dwindling. So that's, in the perfect world, that becomes the standard and protocol.
Interesting.
Just like when you have a baby, they come in, they test the hearing, and they check all the other stuff. Like, we'd want to have the tongue checked as well. Yeah. I also think, we could put protocols in and say what we should all do, but I think maybe just the real simple of somebody, when they come in and they talk, the lactations will come in. I know when I had my first daughter and they talk about why it was important to breastfeed, they definitely talked about how important it was for connection, and they talked about the nutrition value. But they didn't tell me that, hey, by the way, she might have some breathing issues. She might not be able to latch. She might not be able to really eat. It could change the way her diet is. It could change her airway positioning. It could also, there is some research out there now that shows that it can become the first part that could send up somebody down the road of having sleep issues. Possibly we know that there's a correlation and connection to ADD and ADHD with kids that snore and mouth breathe. So if I would have gotten that information, because I did not breastfeed my first daughter. I mean, I have lots of my own reasons, but I don't know, I had made my decision, but I didn't feel like I was given all the information, right? So don't we have the right to know everything? So if we don't educate the parents, how can they make an educated decision?
Yeah.
I don't know. So I think education is probably the first thing that would make the biggest difference. And then after that, so let me just say one thing. I think my bigger thing is that I don't think that people don't want to talk about it, or like they do want to believe in it, or, they want to be able to help people. But I use this thing like, how can somebody, let's say a doctor tells you, okay, you're doing this, this, and this, right? Your mouth breathing, you're doing this. And then they go, all right, well, cool. How do we fix it? And he goes, oh, I don't know. I mean, so, if it's not built, they will not come.
Yeah.
And so it's all about building these programs, implementations, having standards. And I mean, listen, when I first started, and this, it's been like 11 years, 12 years now, and where we are today is leaps and bounds. So I don't want anyone to think that I'm not saying, like, we have done so much growth and we have come so far. It's only exciting to see where we're going to go. But as you grow, new issues happen, like places like the Breathe Institute, Dr. Zog. I mean, the whole industry changed when Dr. Zoggy chose sleep, airway, tongue positioning to become his passion and his drive for research. I mean, it opened the door for so much. So, I mean, you have all these pioneers that are pushing limits and doing things all the time. But myofunctional therapy, and let's go back to like where your fam would come into play here, is what you guys do, in a way, but just in the mouth.
Yeah.
So it's like physical therapy, PT, in the mouth. That's really all it is.
Yeah.
And I feel like maybe we should also use maybe some of your standards more to standardize what we do. So maybe I have a question for you and your fam is this. I always was like, I don't know anyone that ever has had a rotator cuff surgery, and then they go, yeah, maybe do PT, maybe not. Like, I don't know, like, it's not an option, right?
Well, they're doing that for total hips now. Sometimes you get a total hip replacement, and they will not recommend physical therapy. And
can I just be blunt? Is that because insurance is paying? Like, where does it come from?
I'm not sure. I don't know.
I'm sure if we went down that rabbit hole, we could find out.
I mean, I have my suspicions.
Okay.
I think part of it is, and in some cases, they're not showing physical therapy as having good outcomes.
Right, because it's not quick.
No.
You got to put work into it.
It definitely. Absolutely.
We're Americans. We want it done for us.
Yeah.
If you had a PT pill, blow it out the water.
Absolutely.
If we could get some magic Tic Tacs, I don't know.
Yeah.
And I think that's it. The same thing, right? We're just opening the same the same obstacles you guys have or have had is where we're at. The truth is every doctor that's doing anytime the muscle's included, okay, let's just make it simple. If it's muscle, it needs to be trained.
Absolutely.
And if it's in a situation where it has either been restricted, there's a structure, function, or behavioral, something that has affected the structure where the muscles caused enough damage because of the force that is pushing on that, then therefore that has built muscle memory in a negative way. That's it. I mean, right? So fixing the structure and not addressing how the structure got there, to me is, I don't know, kind of stupid. Like, I don't get it. Like, it's like, so the hole and the rain and, right? Like, and not, fixing the hole. It doesn't make you're going to just fix the plumbing up, put the sheetrock back up. I mean, hello, there's a process if you want to really get to the root cause. But, if something's really deep into the bones of the house, it's going to be a pain. It's going to be work. You got to go and do a lot of stuff to it. And that's the same thing here. So it's all about how much are you willing to put into it?
Yeah. And that's the hard thing, because really any type of major lasting change has to do with a change in behavior of some kind.
Oh, absolutely.
Right? If we kind of talked about alcoholism, that being like, well, this is something easy to clear as an issue. Well, you can do all of these wonderful things, but if you don't change the behavior, i.e. you stop drinking alcohol, you're going to run into the same issues.
Or what's the other thing? You're just going to pick up another one, a different behavior.
Yeah. So, and maybe that is what makes our jobs that much harder, is we really have to find ways to induce behavior changes in the people when, as humans, we inherently, if we can be lazy, we will. And I don't think that's a fault, like a character flaw. No. It's just, it takes work, and work takes energy. And
we don't all, and let's give everybody a break. Be honest, is like, what is expected of humans, and for us to survive and add some kids in the mix, and a house and a spouse and a dog and a podcast and 2 jobs or whatever it may be to level up or do what you need to get your hustle on or whatever it may be. There's just not a lot of extra time. And then you also are then to overcome these lifestyle changes, these behavioral changes that are going to have a long lasting structure and functional behavior change, requires self-assessment, looking in the mirror, taking time to evaluate and understand, oh, wow, I did not realize that was affecting this, and connecting those dots. And when that doesn't, you barely have time to do these basic little exercises that we're doing. And yet you think you're going to have a behavior change. Okay. You worked with my mom. Okay. So I sent my mom, and I sent my mother.
No HIPAA violation there.
It's okay. It's my mom. She's fine. She'll be okay with it. She signed the release. But I'm going to use her example. And my mom's good with this because she doesn't know what she doesn't know, right? So she came out, and she wanted to come out because she just wanted to have surgery. Yeah. That was her goal. I mean, she was excited. She's like, I'm just going to get surgery. I'm going to be great. And now here's me, and I'm like, you don't even know why you're going to have. So tell me exactly what's going to change after the surgery. And I was like, no, you're going to go see my buddy. And my mom she knows what I do for a living. She's seen me lecture. My mother's gotten some decent gifts of any little success I have. So you would think she's like, of course I'll go see your friend. And she found out you were out of network. And she's like, oh, he's not covered by my insurance. And I was like, and that's exactly why you're going to see him. And I was like, and I'm not even, like, I was going to pay for it. But think about that mentality. And I'm like, oh my God, I've taught you nothing. Like, I was so like, and then, so now she comes back. She's like, wow, how amazing. I saw her really, trying and working, and she started to feel better. She's like, it's so weird. I feel better what do you mean it's so weird? I get so here's somebody, and I'm using this as an example, like, it is my mother. How is she not getting, and yet when something successful happens, it's like, I wonder what do you mean you wonder what that, like, she knew, but it was like, she almost had to be reminded. It's because of this, because in her mind, the only thing that was going to fix her is if you did this surgery or whatever it may be, right? So, like, if you can play on that, like, not to go into her stuff, but I feel like, isn't that across the board some of the stuff we're dealing with? Absolutely.
Well, it's because it requires you to have some autonomy, and you to have some ownership, and almost intrinsic motivation to better yourself. It's within your control.
And most people don't want to
And it's your
believe it's something that most people, I think, have a hard time being able to, I don't know if it's like they don't want to believe anything they're doing or they could do could better it.
Yeah.
Because then it's on them.
Or something that they're doing is
wrong,
is causing
it. Exactly. Like,
yeah.
I don't know if this maybe when I was younger, I thought it was my worst thing, but maybe it's my one little gift is I have always very naturally been able to, I'm doing that. Like, that's me. Like, okay, I totally caused that. Now, I'm not saying just because I could acknowledge it doesn't mean I always fix it, but it's very easy for me to look in the mirror and be like, this, and this. So I had a really hard time very much of my life. I still struggle with it. Having empathy for people that like couldn't do that. I mean, I'm being really raw and honest. Like I was like, well, what do you mean you don't see it?
Yeah.
So you don't think anything that you're doing is causing that? Like, so with people that will say like, I don't know how that's happened to me. I'm like, you want me to show you?
Yeah.
Like, I'm like, let me show you. Let me point some stuff out for you.
Yeah.
And I think that as a whole in society, I think people don't want to take that responsibility, even though because I guess it has a negative feeling to it, or they feel like it makes them bad, or it goes into, or they did something wrong, they're creating it, they caused it, and then they're shocked that something they could do is positive. It's a mindset change. It's hard for people to dive in and really want to change themselves. I mean, isn't that why like weight loss and gym memberships are like a booming $billion industry?
But we're not seeing the outcomes from it, unfortunately.
And the idea is like, but we were talking about like having the gym membership in your pocket. 1970s, or at least you think anyone thought that there'd be a gym on every corner.
Yeah.
Everybody would have a membership, and like less than 10% of people would actually use it. But just having that membership makes you feel better.
Yeah.
Because somebody really did a great job making the world think that, hey, if you have the intention to go work out, you're halfway there. I don't know if I agree with that, but I mean, you have to get there. The intention is a little step because it's hard to do it every day, right?
Yeah.
They believe that along with it's there, maybe one day they will.
Yeah.
So I don't know if we have forgot to kind of connect. We've made things too easy. We've taken away the hard work part of it. I mean, there's a lot of ways to look at it. So in this industry now, where does myofunctional therapy belong? I mean, that's always a question I think that's amongst most communities is who can do it? Where do you find it? I think it belongs in lots of different areas. Speech therapy, I think in dental offices, in physical therapy. I mean, it's everywhere. I mean, it should be body workers. I mean, there's so many people because it affects, like, it's part of the whole thing. If your mouth is weak and your tongue's low and your mouth's opened, you're gonna be mouth breathing, which the oxygen is gonna change. You're not breathing through your nose. It's gonna cause sinus issues. You're gonna be more likely to have sinus stuffs. It's gonna affect your face. It's gonna affect your craniofacial development, and then that can affect, not that I don't know, but the neck, the shoulders, your posture.
Oh yeah.
A mom told me like, if your teeth are off like this. I was like, so how's his constipation? And the dad's like,
no shit.
the dad's like, well, now you fix constipation? I was like, oh, well, I mean, if you can't chew, you're swallowing whole. It's a little hard for you to, go potty. And the mom, like, she goes, oh my God, we have, only goes to the bathroom 3 times like a week. When it happens, it's really hard. I'm like, well, yeah, he can't, he has no contact back there because he's chewing like this. So texture of food is going to change, the way he swallows the food, how quick he eats, how slow. I mean, it's like cutting scissors that don't line up. And he doesn't even know to tell you, hey, Mom, I don't have any occlusion. I can't chew that meat. And we're like, eat your food, Johnny. Better eat your food. Close your mouth. And literally he's like, so I can't breathe. I can't chew, but I got to do it all. So I'm just going to swallow it.
Yeah.
And then gnaw real quick, get that down. Well, it's going to make it a lot harder for us to digest food.
Yeah.
So,
poor kid.
And then digesting now sleep, right? Now that's going to affect other things. I mean, long term, and I can't imagine that me talking about this, that if we can't go connect us, that people that end up in your position with you are suffering from my stuff, and the people I see that are suffering with this need to be seeing you, right? So it's important to keep the connection going. Yeah,
well, with that, the tongue is one component of the airway, and and we've kind of talked about this a little bit, where with you kind of specialize in airway that's more upper, whereas a lot of the PT stuff that I do is more airway lower. So you really have to I think, blend all of that in order to elicit or to maximize the respiratory capabilities, which has wide-ranging effects. We talked about vagus nerve, and you look at all how the influences that has across our physiology. And
the thing when you were saying, like, your fam, your people, I mean, that's your place. You guys are all cool with that. So the fact of, like, your people and my people, like, why we haven't all sat down and had dinner, like, you know what I mean? Because
until today,
yeah. And I mean, because that's important, because there's so much I should learn from you, and you should learn from me. And I mean, I hope one day that there is a course that helps us all connect the dots, and it's my stuff's included in your education, and our stuff's vice versa, right? Like, the idea is to up the ante and build the specialties, and really help teach the students how to connect the dots. It shouldn't be something you have to learn once you get out of school.
Yeah, 100%.
Like, that should be doctrinated in the beginning.
Yeah. It's almost like you need a different profession that combines it all, or you need a team. And this is kind of where I think you are realizing that you are one piece of a greater...
Oh, I mean, I've known that. I mean, that's always been... But, sometimes you got to do all the work to prove that you need help.
Absolutely.
You got to show where you fall and weak. And collaboration is everything.
Yeah.
But with collaboration, also will bring some other hurdles. Patients, like we were saying before, don't like hard work. Well, they also don't like being told they have to go see 9 people.
Yeah, no, and that's an issue that I've ran into with some people, and I think a struggle with me referring people into this space is when I have that conversation of, well, you might need a few different things. That's hard. I even just look at, like, myself. I've seen, I've been to Lincoln, Nebraska for stuff with the Gelb Splint, and then that took me to getting my wisdom teeth pulled in Phoenix, Arizona, and then that took me to getting the Rotator done in Memphis, Tennessee, and then now I'm in San Francisco getting this, and then working with you, and it's just, and then Zaggy cutting my tongue, and
it's, I mean, and don't admit, there are so many people doing it. Like, and again, I mean, like, I love the Breathe Institute. I mean, I'm lucky enough to be on faculty with them, and I will say that they really set the tone for it. Like, they really brought it together. Yeah. And I do love the fact that when I say there needs to be more, they do have courses for all of our professions. And I do think if any of your fam could go and take one of those, it's going to be huge and so helpful for them and their courses. And there are so many now great foundation courses. But I mean, like, when we're going on, like, a bigger level of, like, how do you really change this? It's hard when you just get out of school, you're in debt, you're trying to work, and now, hey, this is really this is where things are going. Well, now you got to go drop more money for continuing ed. Yeah. And it's not even always some of the courses you want to take might not give you the credits you need. So I always say the hardest part is some of the best classes you're not going to get credit for.
Absolutely. That's the issue I run into is, how the heck do I get my Con Ed taken care of? Because, I mean, no joke, I think it was, I had to rush to get Con Ed for my most recent thing because I was taking a myofunctional class. I took the AOMT class. But then, like, earlier in the year, I was doing a functional medicine class because...
And it's hard for everybody to get. Yeah. So, I mean, like, talk about, we could go to another place of, like, the standard of a continuing ed credit. Why does there have to be, like, why can't it be a standardized, a medical professional credit to encourage people to cross? Yeah. And learn. I mean, you and I could sit all day. I mean, this is the problem. I have lots of ideas. I just have to figure out ways to box them up. And I've always seen how we can always, like, connect and keep going further. So, but that comes back to now, okay, when you're saying, like, this collaboration. So now it comes back to, like, how do you build the ultimate practice? So the question is, like, does that practice look like an airway focused dentist? And, this airway focused dental thing has become like, who is this person? I mean, I hope that one day it's just all dentists, because it's not about maybe there'll be specialists of who does what technique, but the idea of that's how you treatment plan. So they actually, when you go get your 6-month cleaning, it's discussed of what your airway looks like, or, hey, if you're mouth breathing, it can cause more decay. I mean, I don't know if most people know that. When people are like, if you mouth breathe, your mouth's dry. If your mouth's dry, you have no saliva. You have no saliva. You have no antibodies. You have no antibodies. You have nothing to protect your teeth. You're going to get more decay. You can brush your teeth all day long. Yeah. You know, like where somebody else who has tons of saliva, and it goes in like, so these are things like we should always treatment plan to, hey, your tongue is not sitting where it's supposed to. Hey, have you noticed this? And it not wait till it's to the point where now it's like now you mouth breathe, you snore, you this, you have to go and drop, obscene amount of money and insurance doesn't cover anything. Mm-hmm. I mean, that's a shock to the system. So hopefully that will come to a point of that. But for now, seeing groups come together, and it might have a PT, it has a myofunctional therapist, it has, a dentist, a body worker, but now it's also a lactation consultant. It has an adult. I mean, we could go across the board. I hope that will be there, and hopefully we'll have these great little medical mini places that can offer all of that. But you gotta get your group, you gotta get your crew.
Yeah.
And I feel like also as a collaborative group, you got to talk finances with each other. Mm-hmm. What are your patients looking at?
Yeah.
What's it going to cost for one patient to see everybody?
Yeah.
I don't know. How many people know that? Like, if you refer, like, what's the end of the day out of pocket? I don't know. I've always curious like that. Like, I always think of that. Like, so if I'm going to send them 9 people, are they going to be like, so thank you for the, $50,000 journey.
Yeah.
I don't know.
That's probably a conservative number.
Yes. And I'm just saying because those are uncomfortable areas, right? You don't want to talk to your fellow colleague and be like, what you charging, bud? Mm-hmm. What do you think about us working together? These are awkward conversations. And I don't know if they're realistic. I don't know. But I feel like if no one ever says it, no one ever will talk about it.
Yeah. But it can be a big barrier to, like if so-and-so is going to charge $10K for an appliance and that's not in the cards for someone because they're on Medicaid or something.
It's just not in the cards.
Yeah. You have to find a different avenue for that person to get better.
And, I mean, again, going back to things like, so you have all this wrong with you. What do you do? Well, you don't have the money. Good luck.
Yeah. It's an unfortunate thing with our system.
Yeah. And I mean, but let's be honest, I think even in other systems, I mean, do you think they're really addressing this either?
Yeah, probably not.
I have to say that. I mean, I don't think there's any system that's looking at truly getting into what's really going on, which I'll tell you, in all systems, do I think I could sit here and tell you that if we were more aware of some of these breathing issues, we would see a decrease in multiple things, like heart issues, Alzheimer's. I mean, we could go down the line, right? Like kids issues. I mean, the level of things, like if you look at our questionnaires in Myofunctional Therapy, you'll be like, where am I going? Like,
it was extensive.
It's extensive. I mean, we're talking, do you bedwet? Do you do this? Do you chew? Do you stand upside down on your head? Because anything can be related. Mm-hmm. Because that fascia system, I think you're aware of that system.
We are aware of fascia, yes.
Yeah, so
I don't talk much about fascia.
How come?
Because I think if you isolate it to one specific tissue, you're going to miss out on so many other things. Like I think all of this, everything works together, right? Because now here's another thing. We don't talk about the cutaneous nerves in the skin having an influence on a wide variety of things.
We have
muscle.
those? No.
Yeah, right? Wait, skin?
Skin.
So no, I think all of the tissues adapt and accommodate to ensure our survival. And I think if you isolate it to one specific thing, then you're probably missing the boat. And not only that, it's like, say you do a fascial treatment. Mm-hmm. So you mean to tell me that nothing else changed? You were able to isolate the fascia. You were able to bypass the skin, not create tonic changes within the muscles.
Oh, you're saying like you literally going to go through this whole environment and just you had to go this whole journey to get there, but nothing else was affected.
Yeah.
No.
Just like you can't isolate the tongue because you're probably going to also have influences on the teeth, the hard palate, the soft palate, the nasal airway. It all works together. And
I think from your community and your family to ours, most people, and let's just get medical professionals out of here. Let's just talk about our patients, like lays people, right? When you tell somebody like there's something that's connected to their toe all the way up to their tongue, they're like, no. And I'm like, no, really? Because we sometimes also forget, like most people have no concept of what the body actually does or how it actually is affected. Like I find that to be, they have no understanding how, like, if I walk one way with one shoe funny for a long period of time, or that's going to affect the other side of my hip, or that there's a cause and effect situation. And I think sometimes just giving somebody an example of saying like, okay, the fascia just helps connect, it's part of the whole system that helps connect everything. Like I think they say it's like a body, talking, we'll say like a bodysuit and it helps us. And sometimes if you don't grow into your bodysuit, it's a little tight and restrictive.
Yeah.
That helps us try to explain a little bit easier to patients how come the tongue position can affect other things.
Yeah.
So, learning, where other systems can lie too would only make it better for us to talk about it. I mean, I always ask you every time we talk, like, I want to know more, like, what was one thing, the breathing. Breathing. Let's talk about breathing. We're always going to talk, like, when you breathe, you need diaphragmatic breathing, right? Like, you want to breathe
Absolutely.
in. And so in the beginning, we kind of, trying to keep it simple for kids, it was just like a very basic of, put a hand here, and try not to get this hand to raise and sit up straight while you do it, because it's really hard to do it if you're slouched. So it just became like sit up straight, shoulders back, head up, because it felt like it at least opened it. But you had actually kind of had said, it's not always about sitting like that. So, what would be that something to kind of show them that we could help each other?
Yeah.
What would be a way that you would fix that?
Yeah, because I was like, Melissa, I dig you, but
yeah. So and so
So from my standpoint, when I look at that, you have to look at the actions that should happen at the rib cage. So the rib cage should move as you breathe in and breathe out. Because if you think about it, when I take a breath of air in, the tissues that are filling are the lungs.
Yeah.
So the rib cage has to make room for the lungs. And so it has to expand in all directions. So we have these actions at the rib cage called the bucket handle, which would be lateral expansion. You have pump handle, which is anterior and superior expansion, and then you have posterior.
Because it's it's all around.
Yeah. So, but I think what you were trying to do with the belly breath, and I think this is the case of all, is you're trying to mitigate an accessory muscle breathing strategy where I'm lifting the rib cage up as a unit with muscles such as the scalenes, the sternocleidomastoid. Now, the scalenes are a primary muscle, but they also can overdo it, or the pecs.
Yeah.
We don't want that. I want the rib cage to stretch out.
Yes.
So,
but you would normally want to be more about explaining how it's rounded out and how we want to see it go like here everywhere and there.
Yeah.
But we're keeping it trying to be simple, because I'll tell you something, most people I'll say, like, take a deep breath in, and they're or they're like, I am breathing, and I'm like, no, you're just like kind of moving up and down. You're not. So just trying to even get them to, I mean, there's patients I'll be like, push my hand up and out, like, just get them to get that breath.
Well, and then, so when you did that, when you demonstrated that, you emphasized a lot of what phase of respiration.
Okay.
It was inhale. So the issue is, in those cases, those people can't get an effective exhale.
Okay. Yeah.
So you have to get as much air out as humanly possible. And then guess what? So if I am just doing a belly breath, I'm not getting any expansion of the rib cage. Well, you can think of it as like my mentor, Bill Hartman. He uses a toothpaste analogy.
Okay.
So if I take a toothpaste tube and I squish the top of the toothpaste tube, I get all of the toothpaste going to the bottom. Well, the same thing happens with belly breathing. When I take a breath of air in and I do not allow expansion of the rib cage, I have greater downward pressure into the abdominal contents. So the diaphragm will actually descend to the point where it's flat.
Okay.
That creates a negative pressure environment in the thorax, which causes compression of everything, and then you get too much outflow into the abdominal contents, which is the same thing you see in sleep apnea. But now, yeah, because what is that? I have a negative pressure environment. I can't maintain the integrity of the upper airway, and then it collapses. When you're coaching belly breathing, you're creating the same environment, but now you're doing it in the lower part of the airway.
Wow.
And so then now I have a mismatch of intrathoracic and intra-abdominal pressure.
So and 100% correct. So where we struggle with this is most people I've noticed, I say breathe, and they really do not know what the feeling is. Like they they really do not understand what it means to truly get a diaphragmatic breath, to really get that, because that like you see it in their eyes, like to calm them down, so they can't feel that difference.
Yeah.
So sometimes the way we kind of were, like, I'm not saying it's being picked from different kind of systems and that we've been trained on. We got to get them to at least feel it before you can critique it. But the deeper the profession's getting is, how do we evolve it to also get them to feel it, but do it properly to promote? positive. And like also children versus adults is going to be very different. How we do that, how we teach it, how long that habit's been into play.
Yeah.
And I am hands down, if you can't get the breathing right, I think Myo's doesn't have a chance to stand.
No, because the tongue's going to go where you need to go to ensure survival.
Because no one's going to hang out like just walking around with their tongue.
Yeah, especially if you can't breathe through your nose.
Yeah, exactly. To me, the breathing's always been the biggest aspect, been a huge part.
Yeah.
And I have a lot of theories of like people, there's two ways that you end up with mouth breathing. And one is like there was something wrong with a structural situation with the nose early on, and then that created low tongue posture because you had to breathe through your mouth. Or yes, you had a tongue tie, right? And that tongue tie was tethered. You could have been breastfed, but it was further back. Tongue keeps pulling down, and then eventually it just slowly opens, and then you start to mouth breathe anyway, and then you stop breathing through the nose, and then that changes the way the air comes in, and now the nose becomes a face ornament, and it's just hanging out.
Interesting.
And therefore, it's very hard for people to, they think they're breathing through their nose, and they're not. And you know the ones that are like, whew, like they'll like, you put like one of the boom boom sticks, or you try to incentivize some type of nasal breathing, and they're like, oh, you're like, first day with your nose, huh? Like, because,
yeah, right.
I mean, and what's the other thing? Like, at the moment, someone doesn't feel good. I can't breathe through my nose. That's actually when you're supposed to breathe through your nose the most. I mean, like when you're stuffy, like you should be doing nasal sinus rinses 24/7.
Absolutely.
Trying to force yourself to clean out your own sinuses. But we go, oh no, I'm stuffy. It's okay, yeah. That's
not normal.
It's not normal. And you need to breathe more. I'm sick. I'm taping my lips up even more, forcing myself to breathe. And it's hard. Don't get me wrong, but you got to push through it, and you will absolutely always overcome something sinus-wise, a cold or something quicker if you force more nasal breathing. Yeah.
So then, with your treatment process, why don't you talk us through and I know it's going to be case specific, and I hate protocols. Like that was one of my it was a little bit of a beef with I think when you're first learning some of this stuff is they say first you do this, then you do this, then you do this, then you do this. And I think there's some case by case variance. Like, I mean, we're doing weird stuff with me, but say someone comes to you, and we'll say it's an adult, because most of the fam, although hopefully now that we're talking about some of the stuff that
you'll see with kids too.
You're getting taken care of. But if an adult comes to you, and let's say they have these issues, they can't attain a palatal tongue posture, they have difficulty breathing through their nose, they have the gamut, but it's not a surgical case, and maybe it's someone that they just need you.
They just need myofunctional therapy.
They just need you. Where do you start?
So.
And maybe that we could talk into your assessment and
I don't know if I probably will get some. So I always tell people like I do where I do myofunctional therapy very different right off the bat than at most. I only do it in conjunction with dentists. Almost 90% of the time. I mean, there's a couple of patients that I'm close with that I end up knowing they're going to go into an appliance because they're going to somebody, but I very rarely not do it without.
Most people don't have enough room for the tongue anyway.
Yeah, so I'm a big fan. If I could get tongue space, probably tattooed on me, I would. It's all about, for me, that's my objective. Yeah. If you don't have enough space, I mean, if you have a lion and but you only have a little cat cage.
Yep.
It doesn't really matter what we do, right? And so I also don't. I get real frustrated sometimes. Like, I don't know. I guess also I don't love to do things even myself. You'll get change, and there's always benefit. Like even myself, if I didn't do myofunctional therapy, I probably would have a way worse situation than I have. The therapy's done me quite well. I should use myself as an example.
Yeah.
And I struggle with tongue space, but because at least I have tongue strength, I am able to hold at least what I have, so I don't collapse so much.
Yeah.
And it's funny, a CBCT scan, the scan, if you look, my tongue is like flat up because I have like a little cocktail straw. I mean, I have 4 millimeters in my airway. It's really, really tiny.
What was your MAA? Minimum maxillary.
Oh, good question. I don't even know. We'll have to look at my scan.
Yeah,
it was a while ago. It was a year ago. And so we've got it. But so I don't have an option. My tongue can't go back. I mean, game over, right? I don't know, right? So,
how'd she die?
Yeah.
Well, low resting tongue posture.
Yeah. She looks like she suffocated. And that's why I can nasal breathe, because I had no choice, right? It was like, this is what it was going to be, because it felt so much in my throat. So, you can do myofunctional therapy just to be able to sustain what you have if you don't want to fix it, right? And so what would be the base? If someone is really good at nasal breathing, they can breathe. It's fine. They can keep their lips closed, and you can do an easy test like someone just puts a popsicle stick or they hold and just breathe through their nose for 2-3 minutes, and they're able to do that. Then I would definitely do some therapy, and starting off with just doing tongue, just getting to understand where the tongue's supposed to be sitting. And then from there, you kind of go into being able to move the tongue, and then compensation comes into play of can we separate the jaw from the tongue? Because that's when we really start to work the tongue muscles themselves, because a lot of people think they can do things with their tongue, but really their jaw's just doing it for them. And I mean, I'm no way in speech, but I always I ask parents all the time, I'm like, does he mumble? And they're like, well, you'll say, well, do they have any speech issues? Or even adults. Oh, no. I go, has anyone ever told you mumble? Oh, yeah, all the time. That's kind of a speech issue. Because the mumbling is if you do not have a lot of range.
Really?
You'll notice someone will say 1, 2, 3. Their upper lip, inadequate movement of the upper lip, because the lower jaw is just coming. Well, the tongue's down here, so they have to bring it up to speed, right? So they reduce tone.
Interesting.
So they'll talk quicker to get it out.
Yeah.
Or they'll change the words.
Huh.
Because they're modifying. Humans are amazing. We're going to figure it out.
Totally.
So those are areas that we might work in just to help you become more, build awareness. And then body scanning, right? So as an adult, do this tongue, example for you, we got you up to be able to hold your tongue. You can suction better than most. But then
you heard that first, folks. My tongue skills.
His tongue
might
skills are
be
good.
The best.
Yeah, I didn't say best. Those are his words. Well, you are single. They're excellent ladies. Go ahead, go out there. Yeah. So the idea is that you're able to put the tongue up. You get it up there. But now, suction like that. Well, how do we get that to? What does that feel like? Does that affect your neck? Do you feel that down in your back? Does it feel weird? Where do you notice it? Because if I don't build an awareness so that you feel the difference of where the tongue is, what's gonna keep you in the long run? What's gonna keep you doing it?
Yeah,
right?
Absolutely.
So now you come into play as you said you saw Dr. Zaghi. So I actually kind of how I ended up with Dr. Zaghi, how I was lucky enough to kind of get in front of him was I was doing a ton of therapy, had a lot of patients, and I got them to a position, and there was just nowhere else to go. And I'm a little thick-headed, so I just kept going, and they're coming to my kid's birthday party, now we're friends, and they're like, oh, who are they? They're all my patients. I just can't. And I got frustrated, and I'll never forget, it was, so I have a bonus baby. He's my surprise, and so 2017 going in, and I'm very, very pregnant, and I had this time, and I'm watching everything Dr. Zaghi's putting out, and I'm like, what's this guy up to, whatever, and I was like, oh, okay, I gotta ask this guy, what about these patients? So I actually started paying for consults for all my patients, just so I could get on this, so I could introduce the consult, introduce the patient, present it, and ask him why they can't go any further. And the joke was that eventually one day he was like, so are you on staff? Hi. I was just be me again. I'm presenting patient. And now I felt like, oh my God, someone was finally able to say oh, the tongue, he's tied. He's posterior tongue tied. He's compensating into this. And now I had somewhere to send them. And I was like, and now all of a sudden the tongue tie got released, and we were able to overcome it. But the ones we couldn't, which unfortunately were more, I shouldn't say my patients weren't. I was lucky enough. I already had the tool in my arsenal. There was expansion going on, right? I was working with doctors. So if it was a BWS which I know.
What's a BWS?
So a BWS is a bent wire system, which comes from the company MyoBrace. And they use BWS, and then they have you wear the brace over it to kind of help do what the Crozat, the theory was to kind of do what the Crozat did, right?
Gotcha.
So whatever it may be, Crozat, ALF, all of these different things, I was lucky enough that I had somebody that we knew we needed to make T-space. That's how we were showing that we were getting results. Yeah. Or then if I would have somebody that would get good expansion, then they would relapse. That's how long I was keeping them. I was keeping them so that they were relapsing with me. Because I was on this journey, I needed to know where it was going. So then now I was able to show Dr. Zaghi, okay, we've done this, we've expanded, and now this has happened. And everything happens for a reason. That's how I was able to really, I'm so grateful for that situation. So now I was able to see, then you add that tongue tie release in there. Now I was inviting them to the birthday party because they became my friend. It wasn't because I felt guilty, right?
Yeah.
That was a really amazing journey that if you added it all together, what you could get out of it.
Yeah.
And maybe that's where it's hard sometimes. It's if somebody just wants to come to me and they say, oh, I just want to do myofunctional therapy. It is a little hard for me to be like,
because it really takes a team to.
It does, yeah. And I have a hard time being like, I could do the therapy, but you don't have enough space. So I don't know. But that's me, right? There are like a lot of therapists do it and then they only need tongue ties and they're able to expand. And that's fine. This was my vehicle and that's what I saw. And I really do think we now finally are like getting into a community. I mean, people are talking about tongue space more and we're more aware of the structure and that you need to be able to withhold all this, be able to have a place for the tongue. The tongue needs to be able to be somewhere so that it can be in the right position. So it is more, and that's what's not easy about it.
Yeah.
But body work goes into that other play. Like I can get someone to get their tongue up. I can make sure they get to the right orthodontist. I get them in the right appliance. And maybe to kind of come full circle here is like, awesome, we've done this. They get the bite. They've changed. But also, you know, they were doing all this therapy practicing and then, you know, they're finally in a good place. They've had the release. They go home and now, you know, they have, a mental, they have anxiety. They have this. They're depressed. I don't know. They get divorced. Whatever their life comes into play. Yeah. And we didn't really get into the fact of what the behaviors were. And then they come creeping back. Or they get a little new doggy that they're highly allergic to and they don't realize it and they start mouth breathing again. So the body, or they're doing, they have neck issues, I don't know, all these different things. I feel like you also have to bring that aspect into it and you have to be able to address all of it. Yeah. So the treatment planning is complex. So most of the time when a patient comes, I feel confident I'm able to quickly say to them, okay, this is what you present with. I know you have low tongue posture, you have this. This is where I would go. I would start with probably looking to get some type of an appliance. Let's open up that bite, work on that structure. While we're doing that, let's work on nasal breathing. Let's while you're getting your structure fixed, let's work on nasal breathing. Let's see how you feel comfortable getting your lips closed, seeing how that becomes comfortable. And then once the structure's done the right thing, then kind of come in, let's bring that tongue up, start noticing where the tongue spot is, and then kind of prepare for the tongue release. Because if I'm setting a patient up, I don't want them to go get the tongue release done until they have tongue space.
Yeah.
So then now I'm going to focus on that. I'm going to keep it pretty structured there. Once that tongue tie is done, now we go in and we do, some swallowing techniques. And we really kind of bring it all around. And hopefully now they're able to keep it. And now they don't have their teeth moving and they're not functioning as much. And if they do move a little bit, they know why. They have the tools in their toolbox to go back and do the therapy again. Yeah. And do things along those lines.
Which gives them a locus of control with their care.
Yeah.
So then is it fair to say nasal breathing, space, step one, you have to have that?
Yes.
Range of motion, I'm assuming, would be second.
So range of
motion. And a little bit of awareness of the palatal tongue posture. Because I would think if you can't.
Yes, absolutely.
I would think if you don't have the range of motion available, it's going to be really tough to attain that position.
Well, so, right, if I go back, so I don't know, for me, range of motion. Okay, so it depends also, right? Like, we have 4 grades of tongue tie, right? So grade 1, grade 2, grade 3, grade 4, and then there's compensation.
Anterior, posterior,
so
all that stuff,
where that treatment plan would maybe change is grade 4. Okay, if you're tied all the way to the tip, I mean, you can't do anything with that. Yeah, you're like this, right? So now we'll do a 2-step release. Initial snip, just so you can do therapy.
Interesting.
Yeah, just get up there. We got to just do that.
Yeah.
Then while we do that therapy, we work on nasal breathing, work on the structure. Yeah. Then we go back and prepare you for the functional frenuloplasty.
Gotcha. Because I have a client who I'm working with right now who he's potentially a candidate for a second step. But so what they do anterior first and then the posterior tongue tie second?
So
or basically just progressively more
so the
motion?
concept of why the therapy is so crucial for tongue tie release, especially a functional frenuloplasty going deeper in, is because they need to be able to do certain exercise, certain motions and movements and hold it during the procedure. Yeah. So you have to remember, they're numb during the procedure. So they better have really good muscle memory and know how to do these things to hold it when you're numb. Right? So you better be able to do a cave suction really well. And also that's going to help build muscle. So now when the doctor goes in and does that release, you're going to see separation between fascia, fascia fibers, muscles. It makes it a lot easier for the surgeon to get in there and see that difference.
Absolutely.
I don't know, anyone that's ever worked for a doctor, anything we can do to make their jobs easier, it's always a win. 100%. It's a win for the patient, win for the doctors, win for everybody. Yeah. So that's what's crucial for that beginning step. So if you're so tied, right, anteriorly, which is a lot of people that are out there that will say, oh, if you know somebody that had a tongue tie release 20 or 30 years ago. I promise you they still need another one because that was a snip. They saw that it was so high they couldn't move it. So they were just doing what we do with the first step to prepare them for the second one. I mean, that's how I look at it.
Yeah.
Yeah. So, look at it. It's like, yeah, we got to give you enough rope so we can at least get you moving, so we can get you to hit the tongue spot, and be able to then hold that cave, work up, get a little muscle tone, be able to, work there so we can get some identifying and be able then to get you ready for healing. And also it's a lot easier to do therapy exercises for healing when you already know them and you've gotten muscle memory when you're sore and in pain than it is to learn them when you're in pain.
Absolutely.
So I'm like, well, why would you not do it before the procedure? Because who wants to be learning something when they're also sore?
Yeah.
And it's crucial afterwards. Once those sutures dissolve, you're doing therapy, every 4 hours, 6 hours. You've regimented. You don't want that stuff to reattach.
Of course.
You want to keep that moving. You want to use this amazing moment and ability to, now your range of motion being so much wider, you want it to continue.
Yeah.
And that's not going to happen. You could see it become worse, tethered up if they don't have a really great regimen and they didn't have the good muscle tone to begin with.
Yeah. Well, and that's something that even in PT, like if we have someone who's going into surgery, we try to see them. In a perfect world, you would see them pre-op for the exact same reasons you're talking about. It makes it so much easier on the back end.
Of course.
If they have those concepts in place.
It's not new.
Yeah. Yeah.
Most of us have all been doing it. It just,
it
goes back to the implementation and trying to make sure people understand it. And, I think that's going to be a battle, but I think more conversations like this, more people using their mind and opening up and finding unique places to educate patients. We were talking about something earlier, but not to go into it, but I believe people are a little bit, I'd like to give them more credit than we do. I think people are able to make decisions.
Absolutely.
I think we make a choice, unfortunately, to choose what information pertains to them and what they need, because we don't think that they have the ability to always maybe make the right decision for themselves. I don't know. I feel like all people, this is just should be spoken about. They should know every option. Hey, if you don't want to do if you choose not to do it once you've been given all the information, then hey, cool. It's your choice.
Yeah.
I have an issue when you weren't presented with the side effects if you don't do it. Like I'm sure if I was going in having that hip, if no one came in and told me, hey, listen, okay, you couldn't do the therapy, you could do PT prior, pre and post, this is the benefits, whatever. If you don't, this can happen, this could be a little bit more challenging. Not to everybody, but it does happen. And you truly set the expectations and limitations of both, let the patient choose.
Yeah.
Once they're educated, they know, hey, do whatever you want.
Yeah.
I have an issue that it's not, we don't do that.
Yeah, which makes sense, because then you're not making them an informed consumer.
No.
The thing that I struggle with, and I see this a lot, and I especially see this online, is sometimes when you give someone a story and you give them the doom and gloom of what could happen, a lot of times the maladaptive beliefs that they develop from that become an issue. So, like, there was this article. This guy was named Darlow, and it was like something, I forget what the name of the title is. I'll link it in the show notes. And he had this thing that this patient said. So basically, it interviewed all these patients based on what doctors had told them.
Okay.
And I don't know what the doctor specifically said, but the patient's interpretation of what he said was he was so afraid. He was dealing with back pain.
Okay.
He was so afraid of the disalignment of his back that he thought that his spinal cord was going to sever, and that led to tons of fear, anxiety, lack of movement, and things like that. And I especially think in this domain, because it is a huge rabbit hole, and there are some scary procedures that some people may have to go down. Like, sure, we're talking about appliances and myofunctional therapy and things of that nature, but what if you got someone who needs the MMA surgery?
So let's go.
How do you balance not instilling fear and maladaptive beliefs that this is, like, if I don't do this, my life is screwed, versus informing
this is
them?
what I know, I'll just live with it. And I truly understand that. So I said to you, like, I have 4 millimeters of an airway. I do this for a living.
Yeah.
Very aware of what I should do, right? Like, do I know that I should have surgery? It's scary.
Yeah.
And I know some of the best.
Mm-hmm.
I also know the other side, right?
Mm-hmm.
It's human.
Yeah.
Like, I'm going to try this first. I'm going to, like, you know, it's a scary thought. And yeah, let's be honest. I go into, like, do I have it in me to do, you know, my own insecurity of, will I follow through? Will I get it done? Will it truly make a difference?
Yeah.
Another thing is this, like, I'm high, you know, I'm always high energy. I'm all this and stuff. I'm always like up here, right? My fight or flight. That's become part of my identity.
Yeah.
It's who I am. Is there something inside of me that also steers away from it because I'm scared of who I would be without it?
Yeah.
I mean, I'm going a little dark here and a little deeper, but it's my truth.
Oh, for sure.
And I play in my own head all the time. Like, I'm like, I can't do it this month because of my kid. Like, you know, and I can make every excuse not to do it.
Yeah.
Because at the end of the day, it's huge.
Yeah.
And it's a leap of faith.
Yeah.
And, I think I respect that. And I hope that nobody thinks that anyone's saying it's easy and it's one shot and do it. But the question is then the other comes back to is maybe I just don't think it's affecting my life that bad yet.
Yeah.
Even though I know it probably is, I statistically know it is.
You know what you don't know.
But the other thing is, maybe I'm uncomfortable like this. I'm not ready I haven't hit my place of like, I can't do this anymore. This is I can't live like this, right? So I'm willing to go do that. Yeah. Where I think like in some ways, like those are extreme cases, right? But, kind of just to go to a way like, let's go to like rotator cuff surgery, right? Like, so that's not something if my arms, like I can't move it, I don't really have a choice. That's the bottom. I got to fix it. Yeah. Where I'm almost in a sense saying like, what are we doing where why are doctors not, of course PT or after, like why would that not be automatic? I mean, that's part of it. I feel like to say that if that's not always going to be this, if that's not the standard, that's scary.
Yeah.
And same thing, like you've had braces 3 times. Okay, like
what's the 4th time gonna?
Yeah, I mean at this point, like, do you want to try something different?
Yeah.
So you've had braces 3 times. You're going into and you also have sleep apnea, so there's a lot of things that are coming in your way that you have to pay for this, and this. Hey, do you want to also address these other issues? And maybe we get through there. Just those kind of conversations.
Yeah, you have to give people options.
Yeah.
It's funny when you're mentioning the identity stuff because I totally run into some patients who they will forever be a patient because that is who they are. That is their identity. That's who they've become. And yeah, you do have to wonder, like, if I take that away from them. So you're you're high energy. Well, if if
I lose it, what would I?
You get the chill pill, yeah. And I think it was in Mark Manson's book, not the subtle art of not giving a, but everything is. He talks about. I just read it the other day. Oh, in order to change who we are, we have to mourn who we were.
That's
yeah,
that's
which
really
is such a profound quote, and it's true. It's like some people just might not be ready to go through that grieving process of changing those things, those dark things that are about you.
Well, if you're anxious, you're living in the future. If you're depressed, you're living in the past.
Yeah.
If you're right, and if you're content, you're in the now.
Yeah.
It's hard. I mean, mental health probably is what. That's probably what is my. That's my thing. I feel that like or
in terms of like it being the X factor, maybe.
Yeah, I feel
the thing we're not addressing.
Sorry, it's personal. Like so, that's like my connection to certain things. So like I had a patient in an office I was at, and I walk into the room. They had the scan up. I mean, the kid has no airway. I mean, never mind. Forget the craniofacial stuff and forget the teeth. Who cares about the teeth? I like turned around. I was like, I just wanted to get hey, but they're like, he was nervous. He's all these things anyway. So I was like, great. I got the assistants to take him out of the room. And I said, so any behavioral issues? Like the mom just starts crying. I mean, anger issues, can't calm down, digestion, bathroom issues, can't eat. Like, and I'm like, I want to like just like cry, right? Because I'm like, this is a kid in my mind, this young man. And the mom is like, she thinks it's just who he is, right? Like, you know, we have one bad seed. Because I'm telling her things, and she's like, so that has to do with that, and like with a little bit of disbelief, right? Like, yeah, right, lady.
Yeah.
No joke. The father was in there, and he had a mask on, didn't say anything. And I brought up one thing. I said, so is he really good in like science? And then all of a sudden, like his reading and comprehension seems to be lower. Mm-hmm. And the mom's like, well, I mean, yeah, he gets stronger grades there. I go, has he ever told him sometimes like he's read a page and he doesn't remember when he gets to the end of it and he's got to keep rereading the same page? Mm-hmm. And the dad like takes down his thing and he goes, why? He gets that from me. Dad pulls down and he has this crazy deep bite. And
wow.
I go, you didn't get it from you. I go, you just have the same habits. And he's like, what? I go, you both like, you live in fight or flight. Like I go, just start reading out loud.
Yeah.
It will change the game. The dad was like, no way. So the mom's like, I go watch this. So the kid came back in. We gave him like one little like snippet of a thing. We told him to read it to himself. I gave him 3 questions. All 3 were wrong. I had him read it out loud. 3 same questions. He knew him right away.
Wow.
It's just because he can't hear the noise in his head so much. He can't it's blah, 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 because it's spaceships and mom and
so
anxiety.
So you essentially recruited another sensory system.
Absolutely,
to help.
yeah. Mm-hmm.
Well, and then that goes into, and I don't know if you ever check this with those folks, like if they have any visual issues along with that, because a lot of times.
Zach, I gotta fix it. I'm fixing bathroom issues. I'm like, can you now I gotta fix eyes? No, no.
Well, but that's why,
we gotta send over to the
Absolutely, yeah. Which, Dr. Kareen, if you're tuning in.
Oh, okay. I'm sending.
I gotta introduce you.
Okay, I'm sending it away. I mean, and I'm so sorry. Not that I don't know how important the visual aspect is.
Well, to me, I think this all relates to airway because if I have to assume a particular head posture, well, that's going to change where my eyes are looking in space. And so you could potentially see some changes in the way the shape of the eyes potentially, or the focusing type stuff.
Because they squint.
Or eye teaming.
Well, we look at it when they squint. Well, actually, I always look. Like they always have my little super, what do you call it? Like my tarot card thing is I'll walk and I'll be like, oh, so you only chew on the left side of your face. Yeah. Before I looked in their mouth and they're like, what? I'm like, well, because one side of your face is stronger than the other.
Yeah,
like,
yeah.
I can tell you only work those muscles. Yeah. But also like the moment you bring somebody up and expand them out, their eyes all of a sudden open up because they were squinting like this. And so I guess, I mean, I knew the eyes were I knew the part of the face. But yeah, everything's affected. I mean, so let's just wrap up on one last thing. I mean, now we've done ears, but we've done eyes and mouth. So kids that have had tubes in their ears. Mm-hmm. Okay, kids that have tubes in their ears can't swallow. That's why they can't clear their gestational tubes. So if they have a swallowing issue, that's why it keeps building up fluid.
Yeah,
so,
interesting.
Yeah,
so wait, you're gonna have to unpack that a little bit because this is so if someone has eustachian tube dysfunction, how does that relate to the swallow? So are you saying that?
So normally what happens, right? So swallowing, and again, I am not 100%, but like it's the idea, the concept of the swallowing is what helps clear it. Like it helps the fluid run through. Yeah. So if
because it has attachments into the
ear, nose, throat. I think that's why they're ENTs. No, so
you down with the ENT? You
know what I mean? Yes. So the concept of like if you can't swallow, like so if your tongue's low, so swallowing for anyone who doesn't know, right? So tongue should be up. You should be able to swallow with minimal facial movement. Yep. Tongue should just go up. Down, up, very easy, right?
So it kind of scoops it back. Is that how you're approaching a swallow? Or it's almost like a whip.
Yeah, whip's good. Yeah, it's like, but the idea is like I drink. It's actually suction kind of back, right? It should have like a natural sliding back to it.
Yeah.
You know, kind of in a way, something along those lines. But minimal movement of the face. So the idea is like swallowing should not be exciting to see because you shouldn't see it. You know, something silly like that. And the truth is, when that doesn't happen and you got to work multiple swallows, like this is where chewing and bulbous preparation, people that have to multiple swallows always have a drink while they're eating because they need assistance when they have to swallow their food. When all that comes into play, well, when they're little, if there was a true issue with the way they were swallowing, it doesn't clear everything, right? So, you know, they're more prone to get ear infections, or now the tubes are in and then the tubes came out and we had to re-put them in. So, and again, I'm sure ENTs will come back and be like, well, there's so much more to it. And I absolutely, I am not giving it near all the justice it deserves. I'm just saying, so when I'm going through and I'm looking at somebody who's had tubes twice, They've had multiple ear infections. They have tonsils that are pretty enlarged. They have an elongated face. Their teeth are crowded. I mean, like, how many things? There's enough there to show, like, there's something bigger going on here.
Yeah.
And those are my other things. My other thing is, like, if your tonsils and adenoids were taken out when you were really young, I'm always like, why? What created the tonsil and adenoids to be so large? I just want to know why. Like, that's right. So is that maybe because they were breathing with their mouth a little bit more and the tonsils and adenoids are a secondary filtration system? It's a backup because they didn't nasal breathe as much as they were supposed to. So it kept the tonsils and adenoids constantly enlarged and created a lot of pressure in the back of the throat. So of course, we took them out and everything got better, but then we didn't address the fact that they really never learned how to breathe with their nose. We just took it away, and now they just continue to mouth breathe. Now they don't even have any filter.
Yeah.
I don't know. I assume that the saying, you have no filter in your mouth, came from that.
Interesting.
Yeah, I don't know. I always thought that.
I kind of like it. I mean, that...
Yeah, you have no filter. So I always walk around and I have no filter.
It's because you had your tonsils.
No, I just have no filter. No, I actually have my
But then
tonsils.
if you did get them taken out.
But
you
here,
really
I
have no
had
filter.
tonsillitis like 9 times.
Really?
And I was like, why? I asked my mom, why didn't you take them out? And I don't think she wanted to tell me, but they probably did. And I guess lucky for me, my mom didn't make it to that appointment. I don't know. But I had tonsillitis. Only reason I remember one summer, I was in bed for like 6 weeks, and I remember like listening to all the kids play outside. And I mean, I would get...
Dang.
And till this day,
Yeah.
if I've been like traveling a lot and doing things, I'm definitely, first thing that goes, my voice. And it'll dry and I'll get a sore throat. I was always that kid. So I did have those issues. And I I was grinding my teeth like there was no tomorrow.
Yeah.
But I never had braces.
Wow.
Because why? Because my tongue was plastered up there. I had to have a decent shape. Because I don't know where, like, it was right there. But I didn't grow forward because I was keeping everything like this. So it should be out, right? But I'm usually like, what would my face look like with me? Am I going to be all the way out here?
Yeah.
What's the rest of my face back there? I mean, in my mind, this is what you think of, right?
Yeah,
I'm
absolutely.
like, if I'm going to have that done, I also got to have like cheek implants. I got to have my eyes brought out. I don't know. But so, I mean, you know, go that way.
Everything to go
Yeah.
forward, basically. Yeah. Well, Melissa, you've been amazing. I could talk to you for probably another 6 hours. But where can people find you?
So melissamugno.com is my website. I'm not doing so much of, seeing patients as much. I mean, I'm seeing some, whatever, but a lot more coaching, a lot more helping people guide and build treatment plans for them. And as well as connecting them, I can always, reach out to me, send me an email. I can get you involved working with Sarah Hornsby, doing some stuff with Faceology, online myofunctional therapy companies. There's a lot of big stuff coming out in the next year. So definitely stay tuned. We're definitely going to work on getting some training and platforms and programs and just so much more education. Definitely hoping to get some type of patient landing page where maybe they can like reach out and ask providers questions and
that's amazing
and stuff. And any of your homies, they want to reach out and we want to do a multiple podcast. I'd love to get more people involved. We can do a Q&A.
Yeah, that would be great. And if you've been an amazing teacher for me. You've definitely helped me apply some of these concepts with my patients and clients quite a bit. And I mean, there's a reason why I had you on here.
Thank you so much. I'm really excited, and I'm hoping one thing comes out of it is we just end up more people and get involved, and we just cross and ask questions, and we can all help each other out.
Yep, absolutely.
Thank you so much.
You bet. Thank you.
Thank you.
Hello. That's how it's done. Give it.